So I'm going to speak with you about systemic disease in the Fontan circulation. And your chair this afternoon has coined the phrase, the Fontan circulatory syndrome, which I really like because I think it really summarizes many of the things that we see in the Fontan. So I'm going to focus just on some fundamental principles of the Fontan circulation that will contribute to the systemic manifestations of it, and then look at some of the manifestations, many of which you know already, and then perhaps just speak about an approach in very brief terms, because we still need to do a lot of work in this area. So just some fundamental principles about the circulation that drives this chronic circulatory state then. And the first thing that happens with institution of the Fontan is that cardiac index drops. And similarly, CVP rises, and you can see on the left is the normal values, and then after institution of the Fontan circulation, the pressures increase as demonstrated. Ventricular function, however, intrinsic ventricular function does not change with institution of the Fontan circulation. And here's the preload adjusted ventricular maximal power as a unit of volume or area in the ventricle, and you can see that's really not very different between the Fontan and the normal circulation. And when we look at diastole, which Werner will talk to us more about later in the session, you can see that the filling rate of the ventricle is definitely reduced, and the relaxation may be a little more prolonged. And when we look at the arterial properties, there's clearly a difference between the Fontan population and normal. And here you can see that the arterial compliance or elastance is clearly increased in the Fontan. And this is perhaps not surprising. This is some histological data from a series of patients with a failing Fontan circulation, which we have just published. And you can see in the top slide, this is a normal aorta with nice vascular elastic tissue in the media, and the intima is very, very thin and normal looking. This, on the other hand, is a slide of the aorta from a failing Fontan patient, and you can see this enormously expanded intima, and then also an abnormal media with some breakdown of the elastic fibers and some increase in the ground substance in the muscular media. And this is just another view of this, and you can see this greatly expanded intima. This is actually in another patient in this sort of fibromuscular deposition on the intima of the aorta. And here you can see very nicely the fragmentation of the elastic tissue in this aorta. So perhaps not surprising then, we do see abnormal coupling between the ventricle and the peripheral arterial circulation. And here's abnormal values being documented in Fontan patients. And this is lovely work from Hideki Senzaki from a few years back. So not surprising then, when we look at what happens when we stress the Fontan circulation, all these values are really very significantly different and become very exaggerated. So in the black on the top, you can see this is a normal exercise response to with an increase in cardiac output, and in this instance it almost increases threefold during exercise. And this is a Fontan circulation patient with lower values to start with, and then as exercise commences, there's really a very small increase in cardiac index. In this patient, it does double, but it really does not compare to normal. And then you can see also at the end of exercise, if you add an expiratory load, you can depress the cardiac output even further. And this speaks to the effect of the muscle pump and the respiratory pump during exercise. So now the next component then is the venous circulation and venous pressure responses during exercise. And I've just taken a sample of a patient here who starts off with venous pressures pretty normal of 14, And this patient exercises and has a very rapid rise during anaerobic threshold and peak exercise to get to above 35 millimeters of mercury toward the end of exercise. And you'll also notice that this does have impact on end organs. And in this instance, we just looked at the liver, and you can see the liver stiffness starts only mildly increased. This is shear wave velocity of 1.7 meters a second. You and I will have shear wave velocities, assuming that you don't drink too much, of about 1.1, 1.2. And so this is a little bit elevated and at baseline, but that goes up profoundly, almost to 4 meters a second. Now, not surprising then, the manifestations of failure and the manifestations in terms of mortality span across multiple different organ systems. And this is work that we did just from a meta-analysis looking at causes of mortality in Fontan patients. And as you might expect, cardiac causes predominate, but there's also a very important contribution from each of the other organ systems in terms of the lungs, renal disease, thromboembolism, infection, protein-losing enteropathy, and so on, and increasing also a significant proportion of patients have malignancy. So let's then look at the individual organs and manifestations, and many of this you know already, so I will go through this relatively quickly. So firstly, venous insufficiency. This is a beautiful study done by Anne-Marie Valenti and the Boston group and Amy Batt a few years back, but demonstrating the very high frequency of venous insufficiency in Fontan patients. And the prevalence they documented almost seemed unbelievable, of 60% in our patients. And a third of these patients had severe venous insufficiency. Now, what was interesting about this data is that many patients had signs of venous insufficiency or venous valve insufficiency in the absence of necessarily clinical signs of venous insufficiency. And the theory really is that with high venous pressures, whether that induces inflammatory changes in the venous valves causing venous insufficiency. But there's also a very interesting body of literature on specifically venous insufficiency in other contexts, and this in itself is a very powerful and very potent inducer of generalized inflammation in patients without cardiac disease. And the inflammatory changes that arise in the abnormal ectatic vessels is really quite profound and may have effects centrally in our patients. So secondly, the liver. There are multiple mechanisms of potential liver injury, and you are familiar with many of these, so I'm not going to go through all of these. I want to perhaps just highlight a few aspects that we don't often think about. There's a very nice new data set in an experimental setting of microvascular thrombosis as a potential contributor towards liver disease. And this has been in an animal experimentation. And this perhaps is worthwhile of further exploration in our patients. And then perhaps I also wanted just to point out that the lymphatics, which Vibeke has just been speaking about, may also well have an important contribution to the development of hepatic changes within the liver. And there's, again, some very nice animal experimentation which demonstrates that if you just tie off the thoracic duct, you can induce some really important changes in the liver, which very much resemble what happens in the Fontan circulation. And perhaps just lastly to point out that the element of hypoxia or hypoxemia during exertional stress may well be a contributor to the increased matrix tension in the liver. In other words, the combination of matrix distension and whether this is cyclical or not, in addition to hypoxia, may well be a very potent inducer of fibrosis in our patients. Wendy Book introduced me to this paper, which was published a number of years ago from Japan. And this was work done in dog subjects. And what the investigator did was to tie off the IVC above the level of the liver, and then also add a pump that can regulate the pressure in the IVC and then look at liver function as they do this. And the arterial ketone body ratio, as this goes down, is an indicator of the sort of energy status of the liver and really how much damage occurs within the liver. And you can see, really, by the time you hit 20 to 30 millimeters of mercury, there's significant effect on the liver in terms of the sort of redox state, in terms of arterial ketone body ratio. So the venous pressures in itself has potentially a very important role to play as the pressures increase. Now, this is work from Angie Yateman a few years back, and she showed clearly that there's progression of liver disease over time. And what she demonstrated was, if you start off normal, within a 3-year period, 50% of people will have new abnormalities in the liver. And then if you look at patients that have cirrhosis, 45% of them over time, during the follow-up time, will develop some element of decompensation, whether this is hepatorenal syndrome or hepatic encephalopathy or hepatocellular carcinoma. So clearly it is a progressive state. So looking then at the kidney, this is a lovely work from Sasha, published in Heart last year, just showing the spectrum of patients with renal dysfunction in the Fontan population. And it's certainly been my experience in the perioperative period that patients going in with renal disease perhaps has a very important contribution to poor outcomes in patients, for example, undergoing Fontan revision surgery. And this data set has been helpful also to indicate the influence of renal dysfunction in terms of outcomes. And here on the y-axis is survival free of non-elective admissions or death. And you can see that renal function does play an important role and is an important marker of outcomes. This is a lovely paper from Ohuchi from Japan, and what they looked at was renal vascular perfusion and Doppler studies. And from their data, what they could see is that patients with a renal resistive index of higher than 0.81 really had very poor survival. And this is perhaps a very useful marker for tracking our patients. We still need more data in a bigger population, but this seems to be an important marker of outcomes. Now, Vibeke has already spoken about lymphatics, and all I really want to point out is that the very state of heart failure increases the lymphatic load and lymphatic burden. And this is data from St. Louis a number of years ago, and all they did was to put in a little cannula into the thoracic duct through the supraclavicular fossa and check the drainage rate of patients. And so patients with heart failure had anything between 3 and 30 mils per hour of drainage of lymphatics. Absolutely extraordinary. And these patients would have venous pressures not that dissimilar to what we have in our Fontan patients. And once the lymphatics breach endothelial cavities in the gut or in the bronchi, really there's a very potent stimulation for the inflammatory cascade, and similarly for thrombophilia. And I think this produces a cycle of activity which then we can see may well contribute to deterioration of the patient's general status. And not surprisingly, we see poor survivals like this once it is manifest. So I'd like to conclude then and say, what can we do about this? And we are very much at the early phases of really appreciating a systemic disease burden. So standardization of assessment, and I know there's a number of groups working on this. Again, your co-chair, Dr. Reichik, and many other folk are working on standardizing this assessment. We need longitudinal data collection to help us prognosticate, and also, importantly, not just prognostication, but to see which markers are going to tell us about symptoms in our patients. And then also, I believe strongly that these investigations should help us to readdress problems in the Fontan circulation, dealing with the LPA stenosis, dealing with increased pulmonary vascular resistance, and so on. And then also, I really want to make a very strong bid for developing new endpoints for drug trials and for clinical trials. And these really need to incorporate dynamic responses. The days of single resting values, I think are really perhaps not as helpful anymore. And I think nowadays we really need to go on to dynamic testing and have new endpoints that will help us treat our patients better. So I will finish with that. Thank you very much.
Thank you so much, Christian, for that comprehensive review. If there are folks that have questions, if you could please step up to the mic. Questions for Christian? While we wait, if I could ask a question of you. For the liver dysfunction that we see in Fontan patients, I think many of us, take care of patients like this on a daily basis, and I think most of us can say that these patients, even though they have advanced grade fibrosis or even cirrhosis by radiologic signs, the functional aspect of the liver is very different than in inflammatory hepatopathies. And on your last slide, thinking about different metrics to be able to measure for these patients, just curious what your thoughts are in terms of future functional assessment of the liver in these patients, especially pre-transplant eval, and how that can kind of be practically done in the day-to-day care of these patients.
Yeah, I think that's a very important question, Anita, and I think really if we can answer that question, then we will really serve our patients well. I think a couple of things spring to mind. One is, I think the resting function that we obtain, so resting synthetic function, for example, I think is a very blunt instrument for telling us how patients are likely to behave perioperatively or after transplant or after important surgery. So really we need some finer instruments that will help us define the reserve of liver function. And one of the challenges, though, with defining exactly what that is that the liver probably has 90 or plus different functions, and which ones are we going to concentrate on? And that's a tough one. But I think there are some global tests that we can do. Firstly, in terms of factors that may be more sensitive to a synthetic liver function, something as simple as factor V may be very helpful in terms of defining synthetic function, and that drops perhaps a little earlier than albumin would, or the INR would change. Other things to think about is in the past we've done a study on indocyanine green clearance, and I really found that a very helpful marker. And the challenge with it is it doesn't just assess liver function, it also assesses the circulation. But I don't think that's necessarily a disadvantage, because what it measures is how long does the indocyanine green take to circulate through the system. What it also measures is how quickly the liver degrades the indocyanine green, so the clearance level. And the combination of function and of perfusion, which you can get in one setting, is really very helpful. But I think the dynamic nature of testing, I think, is what we really need to focus on, and trying to understand better functional reserve. But we don't really have very good options at the moment. And I think that's something that we need to explore over the next little bit.
Comment with perhaps getting your reaction to this. It's not a very specific question, but just a construct, if you will, about these individual human beings. We are identifying these morbidities in these patients. They have a birth defect of the heart. However, I think what we're beginning to appreciate is that it's naive to think that that's the only organ system that might be congenitally different from the get-go, either from a functional perspective or an anatomical perspective. Now, no question, the aspect that's most recognizable and the one that we jump on when these human beings are born is the birth defect of the congenital heart disease. But as we're looking at other organ systems, let's take the brain as a model, we clearly now know that the brain is built differently when you have a single ventricle type heart disease. to what extent might these other organs be involved as well in some yet undefined subtle way? And how can we begin to discriminate between what is the substrate that is different in these patients from the acquired changes in relation to the Fontan circulatory syndrome? And this relates to what Vibeke was talking about earlier in terms of the lymphatics. No question that when you impose a Fontan circulation, you're likely going to be changing the functional aspects of the lymphatics. But is the lymphatic map different from the get-go in patients with a birth defect of the heart? So, thoughts on that, and in particular in relation to the liver or other organs?
Jack, I think you make a very good point with that, and I think the liver has perhaps presented us with as much insight as the brain has for these patients. And we know from the work that you and the CHOP team had done that very early on after the Fontan, there were many patients that already had liver abnormalities preceding the Fontan. And also perhaps some data from Jonathan Dillman, who was working in our group but previously worked in Michigan, that some patients, when you look at liver abnormalities before going into the Fontan surgery, it's already manifest. So it seems very clear that it's not, the hemodynamics is not the sole reason for things going wrong. And I don't know if that is a sort of primary genetic predisposition, or if actually there's some epigenetic modification that happened in utero with the circulation, as you've described very well in the hypoplasts. And my, I think it all points in the direction that we try and explore these. But as we do the exploration, though, it seems to me really important that we try and direct our research in ways that will be also helpful to the patient, meaning that as we explore the responses, at the same time we need to also explore drug responses, or we need to explore responses in terms of rehab, as Anitha is doing in the ARC group. So we need to find some solutions as much as we define the sort of nature of the problems at the same time.
Are there any other questions for Dr. Veldtman? Christian, thank you so much.
Thank you very much.